Next, I'd like to invite Dr. Myung-ki to the stage. He's going to present Health Equity in Korea and Examination of the Social Determinants of Mental Health and Suicide. And following his talk, I will be the discussant.
25 minutes. Yeah, good afternoon. My name is Myung-ki. I'm from South Korea. I think the slide hasn't changed. Okay. So can you go back? Yeah, it's the right one. So I'm not boast of myself, just showing that this topic is combining two disciplines. One is in general the social epidemiology, and the other is mental health and suicide issue, and how they two areas help each other, and how they bring the issues in our the attention. So and I did a kind of opportunity. So in some early days, my research focused on the health inequalities and social epidemiology. Then I started to studying the mental health issues. And the first one, I'm recently I started my volunteer job. That's kind of my best choice of this year. So I'm trying to be a nice person. So yeah, social epidemiology, that is an issue, and even if the mental health develops for themselves to solve their problem, they need some social concept. So it generally shows there is an issue, health issue, which is having a strong components of the social issues. So, so by measuring the health inequality, or to understand the situation status, and also to solve the problem. So the mental health is for me, is exactly in the center. So health alone approach is not enough to see the problem. So it requires a help from the social approach. This is the Korean situation. This one and the next one is very, like for us, it's a tragic, but two slides shows common things. That's for me is a lacking of the community support, and if community work is insufficient, what happened? What could happen? For me, it shows like that. So, how long the mental health psychiatry patient stay in hospital. So, Korean records #1 is incomparable to the average OECD countries figure. So, we record about 180 days compared to the OECD average about 30 days. Also, now I think everybody knows. So we record the suicide very long time, not just high, but consistently high. So there were countries like Japan and even Lithuania and Hungary and even Nordic countries. They, in some years, for some period, they got a very high suicide rate, but they get back to their routine. But we are failing again. So I think when I think about the suicide, my answer is a kind of giving like a pre-conclusion to you. But yeah, so I try to say the social components in everywhere, having a chance in Korean conference or the meetings. But yeah, so but in mental health and the suicide, they having already the concept for the social intervention, and that is very fit with the social epidemiology, like Margaret White had, strengthening individual, strengthening community working condition, macro policies, but it is already there in mental health. And also, so you may not understand, but that's the thing happening in Korea. So even the global standard and every concept around that mental health and suicide, that pressures to introduce a social intervention, but it is simply overlooked or underfunded. That's the kind of my understanding of our situation. And I think some of you are already familiar with this figure and Jeffrey Rose's population level approach that is strongly urging the risk factors that is distributed over the population. That is important rather than the high risk group approach, because high risk group approach only take their measure for the small group of people. So, but already in mental health, with real world data, they showed us similar figures. So, and also the bottom right, the semicircular shaped figure, that IOM, they developed this concept. So from the universal, in the prevention stage, universal, selective, indicated, and then the treatment phase, case management, and then the rehabilitation. That's the kind of concept nowadays we are having in like a chronic disease and for the care for the elderly people. We are thinking about this model, but so far earlier than in mental health, they developed this kind of concept. So the social epidemiology, they added, that's the circle, the red circle part. So we already know universal and there is a universal and selective measures like a vaccination and universal health care. That's the kind of universal things. So in our health area, we are trying to like public health. That is our advance. But also we added social component by which was brought by the social epidemiology. Strongly, they advocate this side. So yeah, this is the kind of the WHO. They developed the based on the universal selective indicator. They all matched our strategy for this. Yeah, so this can be like a universal approach. This group of people, the author group, is in the suicide area. They are reading group, working together with the WHO and reading the very important journal. And they we quite welcome this kind of development, conceptual development. And in the first figure, they show that like this, awareness increasing campaign or crisis intervention, training and education, suicide means and media. Those things are, we say, typical component of suicide measure. And that is, most countries are based on this concept. Korea too. There are so many entry points to the social service, like visiting service workers, counselors, healthcare personnel. And they are like a gatekeeping work or screening work, and then, yeah, that's the early identification, and they expect early treatment afterwards. But yeah, that's the typical example of the current work. So this group showed that like a forest, many trees are there in upper right, and it is the health sector is the only one of them. There's so many trees. That means multi-sectoral approaching. They say whole government approaching. That means we have to deal with social determinant, not just the previous one, like suicide means media campaign. That's important, but these things should be complementary to the typical one. Yeah. But also, not just the suicide, but in the mental health area, we have such a long history for the developing the social intervention concept. So, like a supported education, supported housing, labor market issues, they are all, without that, they have to manage things all to the community. But without this, they cannot, just lose everything. So, and the care model also developed from left side to the right too. So in the early stage, they try to find like a broker model or a case management model. So there is a kind of manager, one person, who coordinates some various cares, but some years later, they say assertive community treatment, ACT or ICM, that is like a team approach. So, team to deal with one case, not just one case, maybe any case, team, but they do the team approach. So, team, there is a specialist for the peer intervention specialist. Also, there is a person who is looking for a job searching and matching for the job, and also some are going around the street to find a proper rent rate or road and rent ready to make a contract for their clients. Those things are all happening. That's the small scale dealing with this social determinants. So mental health, there is already a social concept, but in this, so we are very familiar with to deal with the mental health. We must understand their complexity. So this is the issue of biopsychosocial issue, but as Sarah Mura noted, the psychosocial part is just a lip service. That is sorry for the is not about the U.S. situation, but I'm also in Korea. I also feel the situation is similar to this. So yes, that's my work, and very early days my work, and so compared to the diabetes, cancer, ischemic heart disease, hepatitis B, the mental health areas, they show the strong gradient for the health inequality. That means something happening. Yeah, something without the help from the social intervention is medical alone. That's not enough, showing that. And the other word is not mine. Don't be confused. So anyway, so also we provide some evidence on the inequalities about the mental health issues, but still this dogmatic argument understand suicide is there sometimes say 90% or sometimes 40%. That's the smallest figure I think is contributed by the mental disease. So and then if you agree with this, then the solution is quite simple. We must find the mental health patient early, and we started treatment early. That's the strategy, and that's a heavy road in our national plan, I think, in general. And but there is another, it's very impressive. I recently read this article, and they say there's an example from the European countries during the deinstitutionalization period. Late 1980s to early 2000, the life expectancy of those people with mental disorder increased because they live in a better condition. So community support, community integration, that make them feel better, live better. So they choose the life. So that makes strengthening their life and increase their life expectancy. Also, so we also have a very strong belief about in Korea, in recently particular. So we have a strong belief about their mental psychiatric patients are dangerous because like this, there was an incident, arson incident, and conducted by the psychiatric patient who was neglected in community for a long time, and he killed 5 people. And this thing happened. So afterwards, we had a very strong debate on this. The debate is another how to support the patient, not that. The debate is how to protect so to speak, normal from the dangerous people, and how to make the quick process of their hospitalization. So emergency crisis situation, the process. There's a debate, but there is a different argument about the violence, because when there is, that's the US study as well. So if somebody lives in the same postcode, if they are neighbor, and one is the mental disorder, and the other case is not having that disease, then they record a similar like a violence rate. That means it is not a disease, it is their situation, it is their vulnerability. So that echoes quite a lot to me. So but in Korea, this is the situation. So we are, from the previous figure, we have a very long range of staying in the hospital. So our facilities are heavily under the hospitalization, but showing the rehabilitation facilities in community are very limited. So is limited to 5% of the number of beds. So this is the situation. So I have to check the time. Okay. So there is two kinds of social intervention in general. So one is the macro approach, the other is the micro social intervention. So that's a quite well matched with the social academic concept. So they say social service, like accommodation, education, that's the kind of national strategy or national plan. But whereas the individualized micro level social intervention that directs and happening in the community. So community participation, family intervention, peer-led support, those things. So for the macro social intervention, macro level social intervention, like Italy is famous for the, what's the name of it? The Bazaria? He is the psychiatrist and went to the US in Kennedy period when the US is reading the deinstitutional concept by law. At that period, he studied to run the US model and then he got a position of the Ministry of Health, and then he freed the psychiatric patient from the hospital to the community, and then at those days he made this law as well. That is the not just releasing people, not releasing the patient to the community, but he asked others help. So this is a social cooperation law. So by law, they have to hire those disabled people, including the mentally disabled, to the maximum of 1/3. So that's the huge implication, actually. And it's my work as well. So, so in Korea, just the social protection for the elder people, we launched the long-term care measure around 2009, and also the elder pension at those period, and that influenced the reducing the suicide rate among the elder people. That's the kind of simple argument. I will quick for this, that's right. And then to the micro social intervention that happening mostly in the community level. So we need community building instead of the many mechanisms. There are community organizations, lay health workers, and so that's basically non-clinical method also the increasing social capital, social network, social participation, those things. And also, but it is not another natural phenomenon. Is not happening for themselves. There needs something trigger to move that direction. So government make such a fund. So this is the Canadian model, ABS, ASD, Alternative Service Delivery Arrangement. I think there is a similar case for the US and the UK. We can find everywhere. So, so basically, for the public goods, if somebody or some organization is willing to work for the public, then they are helping the government, replacing government. So they have to, have merits to be awarded some fundings for their work. So in Canadian example, I visited the CMHA. They are a huge organization. 7,000 people for staff, and 11,000 people are working as a voluntary. I don't have their information about the budget, but they say 82% budgets are from the government. So, but I marked the Korean example in just shortly. So we have a very small scale, not very large number of grassroots organization, but they experienced recently in Busan and Seoul, they recently cut because the political objection, very absurd, but this time you probably heard about the silly presidents of Korea make the martial law, and I expect this dark period would go soon. Yeah, would go soon. So also, this is another mechanism for trying to move the private sector, working in the public sector. So paper success is sometimes SIB, sometimes PPP. Those kind of models. So, but also the lay health workers, like this case is the Minsei, Japanese case, but they visited, make a home visit, and they make some contribution. So because basically, talking and visiting, there can be a therapy for those people, socially isolated people. So, but in Korea, I have to bring our case, but yeah, not many successful stories yet. So we made those things happen in Korea as well. So there are many countries who are checking, monitoring about the voluntary or peer-led work, the situation, like the UK in community life survey. Also, in the mental disorder, the peer-led intervention is well known, their effectiveness. So Korea also just started, funded by the Seoul Metropolitan City government. Also, like a gatekeeper, recently in Korea, we made mandatory education for the public sector and for students to learn about the skills to catch the suicide signs or those related suicide, the mandatory education. So we have a debate. I'm quite suspicious about that, but I think at least we can increase the awareness, the importance of this issue. But we have to, because rather than just simply deliver the message and turn on the screen and then just make a mute and then just check. I did some mandatory work. That happened quite a lot. So how to make the real education. So to do that, for me, I believe we need, after the education, some kind of voluntary participation or group of work. Those things maybe should be combined with, so social prescription, that's the kind of concept we are trying to introduce. So this is my small work, and just the last slide. So in mental health, there is without the social intervention, it is maybe the Korea shows the example. We are support the very bad figure, and so there is like macro social intervention, but about community, we need a micro individualize the social intervention, and to operate that way, we need to improve the community organization, private sector, and lay health workers. Those kind of things we need to combine. And so for that side, from social epidemiology or dealing with the social determinants, the knowledge from that, they could be a strong help complementary to the mental health. Yeah, that's my thinking. Thank you very much.
All right, I guess I have to be the discussant, so I will skip the whatever moderator part and then stepping to the stage and talk about myself. My name is Claire Lin. I am an assistant professor from Institute of Health Policy and Management here at National Taiwan University. And I have a master from Johns Hopkins University and a PhD from University of North Carolina at Chapel Hill in the US. So I think Dr. Key has a very wonderful presentation detailing all the things about mental health and health equity. I'd just like to provide some further considerations for us to do research in health equity in mental health. I'd like to recap from Dr. Key's presentations, and correct me if I'm doing this wrong. First, disparity and inequalities in mental health exist, for sure. Well, mental health needs social approach. I think we heard about social approach over and over. Population level and social level approach should be taken to be balanced with high-risk group approach and biomedical research as well. I'm not saying we don't want biomedical, but we want to be balanced. Social interventions responding to social determinants need to be at micro and macro level. I think Dr. Key emphasized that a lot. Research on social inequalities in mental health have a mission to support logics and evidence in the progress. And I think we all agree with those points. So I'd like to provide some further considerations. And just disclaimer, some of the viewpoints are heavily drawn from those two articles and mixed with my own opinion. The first one is measurement. So as the health economist by training, I really hate it when I don't know how to measure social class, social economic status. And I think as researchers, we all have that experience. How can I know what income level is from the household level? Are you going to tell me the truth? Am I going to go into the tax record? Am I going to go into your Medicaid profile maybe? I don't know. So this is just so difficult to do. So the first step, I think measurement is really important. And we really need to try to create and prioritize developing these guidelines and framework just to measure the social determinants and evaluate the intervention that targeting at social determinants. That's easy first step. Second, I think we should improve tracking of the impact of interventions on mental health outcome measures. Surprising or not surprising, mental health outcomes are not tracked in a lot of places. So you might have seen a lot of studies in health equity, health disparities, and you will be shocked that they don't even track mental health at all. So I think that the second step is that we really need to start to track the impact and the outcomes, especially the mental health outcome. We need to really raise the awareness of that. Third, I think trust has been mentioned many times today. We talk about trust. Trust is important. I think we mentioned peer support as well. I think that's part of trust as well. We need to build up the trust. And if your program has like a really high turnover rate, for example, in staff, then patients are not going to be, not going to trust the program, and that will lead to like a very high dissatisfaction. So I think trust is important, and maybe we should just bring things out of the clinic. We should be in a community. It should be a community approach, and that might help to build the trust. I think we've heard about this a lot. Multidisciplinary teams, multidisciplinary, multi-sectoral. We all heard about collaborations. We should bring people from neuroscience, cognitive science, clinical science, intervention science, social cultural fields. We just can't emphasize enough about this collaboration and this multidisciplinary nature. And finally, I think we all, as researchers, we should advocate for the structural level and policy level changes, because social determinants and disparities in mental health are often systematic issues. And I think you all agree with me, otherwise you wouldn't be here today. And so these fields really need to work beyond individual level training. We can sure train more psychiatrists, we can sure train more people to treat people, to deal with the issues. But that won't change the structural level issues. So, for example, a community in high need probably going to have very low access to the treatment, to the intervention, and that is definitely a structural issue. So, as researchers, I think we should advocate for that. So, I'd like to conclude this with this, my own quote. That there is a growing potential to minimize the linkage, stop finding the linkage, minimize it. I like to break it, but that's too ideal. So let's minimize the linkage between social determinants and mental health. However, I think collective efforts will be needed from each of us. Thank you.
Claire and Positive for your very interesting talks addressing the critical issues about inequality in mental health. But given the limited time, so I would suggest we if you have questions, feel free to approach two speakers, and we have break now till 3:15. Okay, would that be okay? So because limitation of time, so feel free to approach the speakers to ask questions, and we'll return to this symposium 3:15. Thank you.